Hello, guys. Good morning. So, when the government announced yesterday that COVID alert level has downgraded from 4 to 3, we had a question like, so how does this affect us, and what infection protocols we need to follow? There's so many different types of mask, FFP2, FFP3, surgical mask. There's so many ambiguity around this situation. So we approached Jonathan Collier. So to give a bit of an idea of what does it all means, how we can protect ourselves, how it will imply to the general practice. But Jonathan Collier has kindly accepted with a short notice to do a webinar just to clarify a few things and just make us aware of the situation a little bit more better. Just to give a good introduction about Jonathan Collier. Jonathan Collier is a consultant in lead consultant in oral and craniofacial surgery in Department of Craniofacial Plastic and Reconstructive Surgery. Jonathan has achieved so many qualifications. I'll just briefly run through. He's finished his MA in Cambridge University, done his medicine in Oxford, and done MRCS in Edinburgh, BDS, MFDS, and also have done PhD and completed his FRCS OMFS in 2010. I used to be a Jonathan Collier's SHO about 14 years back. So I'm privileged to see Jonathan giving us some insight into COVID for that. Without much ado, I'll welcome Jonathan. Over to you, Jonathan.
So, Senthil, thank you very much indeed to you and the Dental Roots team for giving me the opportunity to run through these things. I'm just going to check that you should now be able to see the title slide because Senthil contacted me earlier in the week and said, oh, look, please can you give a bit of an update on infection control with particular reference to masks and dental practice. So in combination with my wife, and the disclaimer is that the knowledge base has come from her and the practical base has come from me. We drew lots. Sophie's doing the childcare this morning and I'm talking to you. So if a small person or a small cat runs across, I apologize. We'll feed that back to management. Anyway, I'm going to just run through a few topics over the next hour or so. I think the moderators are going to collect questions through the chat room. We will stop and pause for those on a few points. But basically, I thought it might be useful just to frame COVID in the current climate, what's been developed, and essentially look at what are the new bits of guidance that are out. As Senthil mentioned, they've dropped the national alert level down. There are some other relevant pieces of guidance that have come through. But actually the meat of the talk will really be in how this can be important for you in the dental setting in this evolving way, and such that we can try and identify some simple practical protocols so that you can face your patients, your staff with confidence to return to dental work. And we'll talk about some different elements of things which have been on lots of people's minds, looking at the chat rooms and feedback that I've been getting while dealing with colleagues. So a bit geeky, bit of science. I know it's Saturday morning, but bear with me. So COVID or coronavirus is a SARS-CoV mRNA single-stranded beta coronavirus, so called because of the halo on electron microscopy. And essentially you have the nuclear core and the spike proteins, and the spike proteins gain access through the angiotensin converting enzyme type 2 receptor, which is predominantly in the lung epithelium. So the sources of contact and transmission are predominantly the respiratory mucosa, upper tract, lower tract, also the conjunctiva, but it's the respiratory ones that are the main portals of entry. When we think about infectivity, how it does this virus demonstrate signs and symptoms, from the point of infection and inoculation, it takes a median of 5 days for patients to become symptomatic. There is a small proportion of patients who never develop symptoms despite being infected, about 17 to 18% from the early epidemiological studies. But most patients who do become symptomatic will have a period where they are pre-symptomatic but highly infectious. And that period between about day 3 and day 5 of infection is the one that still keeps us worrying about whether the patient in front of us or the staff member beside us carries the virus. So if we then look at testing, the antigen testing, so that's usually a PCR test done from a nasopharyngeal swab that will light up from about day 3. But typically people will not get tested until they get signs or symptoms. Antibody tests, there are multiple on the market, and essentially they will look at different immunoglobulin markers, G or M, but they will become positive much later in the illness, so usually 10 days plus. Different tests, different reliability, so need to be interpreted with caution. So much talked about aerosols. We talk initially about aerosols, coughs and sneezes, spread diseases. So it's essentially you are generating the particles either in an aerosol fashion or in a droplet fashion. And that's essentially, we're talking about transmission across populations, usually in confined spaces. And the 2-meter rule, which is currently under review by the government, is based on the fact of how far can these droplets spray out, and that's essentially what they're looking at. And you can understand that it will be a sort of exponential decay the further away you get from the source. Now, while of course it is possible that your asymptomatic patient will be coughing and sneezing in your dental practice, when we talk about aerosols in clinical work, we're talking about something that's slightly different, and we'll talk about that in more detail soon. Okay, so just a quick few nuggets about the clinical features of the disease. Well, as we've learned more about coronavirus, particularly in different populations, it's more than one disease depending on your susceptibility. So there is a respiratory side, there is a coagulopathy, and many of these patients have a lot of thromboses, which can worsen the ventilatory strategies for them. It has a kind of neurodementia effect, certainly acutely, and we don't know whether that has a more longer term outcome for patients. But certainly the ITU patients get very delirious. There is a small asymptomatic group, as I mentioned. Most patients will describe a mild symptom, so dry cough, malaise, myalgia, and that's the biggest group, so 80%. About 15% of patients will get a severe disease, a respiratory embarrassment, ventilatory problems, high fever, and they will often be hospitalized, and about 5% of patients will end up with a critical illness for which intensive care is required. And certainly at the height of the pandemic, the mortality on ITU was approaching 50% for these patients. So what are the risk factors for severe disease? Well, we know that your age is important. Whether you have underlying chronic diseases, whether they are heart, diabetic, renal, if you are immunosuppressed, if you have a particular forms of cancer, you're fat, male, or a smoker. So these cohorts do badly. There's a lot also talked about the ethnicity of the patients, and certainly some of these factors need to be teased out, but there is emerging evidence that certain ethnic groups also do badly for reasons that we don't fully understand. So what does that mean? Well, the government essentially locked everyone up initially, but then defined different populations as either vulnerable or extremely vulnerable. And this information is available through the NHS digital website. And it essentially, it is something to think about when you're thinking about your staff and your patients. So if you have a condition on the right column, then you are an extremely vulnerable. If you get coronavirus, you're going to do very badly. So these patients will still be shielding at home. The vulnerable group, well, anybody over 70, it's a bit of a broad brush, but that's and under 70s, there are different factors linked to what I just listed in the risk factors for serious disease. But one useful screening question is you can ask your patients if they have been medically advised to have the influenza immunization. And that is usually linked to their health records. And if they are advised to have the flu jab for medical reasons, then they are probably in the vulnerable group for coronavirus if they're under 70. So when we look at the impact of coronavirus on mortality, it is difficult initially to tease out the different factors, but one set of data that has been discussed more recently is excess mortality. So how many more deaths are we seeing than we would normally observe during a certain time period? And here you can see from the Office of National Statistics a huge spike in excess deaths kicking in around the end of March. And the blue colored bars were those where COVID was mentioned in the death certificate, but the green bars are actually not mentioning. That may be that the patients are not testing, but certainly from the hospital perspective, we have seen that a number of patients with chronic medical conditions who you'd normally expect to be presenting with heart attacks, strokes, are just not attending hospital. So there's a huge amount of medical unmet health need, and you can infer from that there's probably a huge amount of dental unmet health need. So one of the things you may be finding when you open up your practices is that actually there'll be a bit of an avalanche of patients coming through with things that have been stored up or incompletely addressed through the AAA approach. So if we look at statistics, and these are confirmed cases, so we look at where the lockdown occurred, the data that we had was really lagging behind what was projected. And it's this projection that is going to be difficult for the government to understand. It's thought that in London, at the height of the pandemic, 1 in 10 people had the virus. That is probably now between 1 in 500 to 1 in 1,000. That is the best estimate. And we've now slowly released the lockdown. But of course, the concern is that as we go through this, we release the quarantine, will there be a second surge or a super surge that may require us to repeat the quarantine? Ideally not, for obvious social, economic and other general reasons, but that is what is necessary. So until coronavirus really drops down in a very, very low level of prevalence, then this will still be an issue for us. And I think realistically, we are several months away from that. Clearly, government think that the incidence is decreasing by reducing the threat level from 4 to 3 yesterday, but it's not really until that's lowered substantially further that we will be able to relax these infection control issues. So what does that mean at a practical level? So initially, before the CDO announced that people could return to work, we were kind of in a quandary of waiting for guidance. The indemnifiers were sort of going, oh no, we need guidance. The guidance, so we need infection control. We're kind of going around a loop of inactivity. A few weeks ago, that suddenly changed. And actually now there's almost too much guidance because I think people are finding it difficult to kind of see their way through it. So I thought I would just try and give you a little personal overview of where we are now, and hopefully to inform your decision making at an individual and local level to get you back to work safely. I don't have the answers specifically. The government doesn't have the answers specifically, but I would say that as you listen to this, actually you are going to need to make your own decisions. This is not about eliminating risk. This is about mitigating risk, writing down what you're doing, making a note, doing things to your best ability. And I think that is the approach that you will need to take. So let's have a little think about the current guidance. So this came from the Chief Dental Officer. I'm sure you're familiar with this document and read it many times. It talks about sort of minimal aerosol generation in hygiene, perio, endo, restorative. Again, all looking to try and reduce the exposure in the dental setting. This still is the main document from the UK. There are others from around the world which follow relatively similar principles. The core infection control document for NHS countrywide is this one, initially released in version 3 in May. It was updated a couple of days ago. And this, I think, is a useful one to refer back to. There are obviously elements that are not immediately pertinent to dental practice, but it has now been expanded to talk about primary care, outpatient settings, those sorts of things. So actually, it is worth going back to this and looking through elements of it. But essentially, the core tenets of this at a hospital level or a practice level are planning and scheduling. Essentially, we'll talk a little bit about testing and track and trace it towards the end, and then having robust infection prevention control measures, looking at your patient base, your staff base, just reevaluating and ensuring that it's not a kind of that's it, we're done, regimented things. There's a flexibility to it. Legally, there are still requirements, particularly for employers with more than 5 staff. This must be in a written format, that you must have a form of risk assessment for each step of the process, and this will usually be incorporated into a standard operating protocol. And again, the documents of the infection control can be sort of used as the core for that. This will involve your employees and your non-employees, and the non-employees really are your patients, and then essentially how this was organized and how this was documented. And this is the sort of thing that the CQC will be looking at when they are reviewing practice workload. Now that will be retrospective, but essentially it's good to keep, as the lawyers say, a contemporaneous record of what you're doing rather than trying to do this reactively. So write down what you're doing, write down why you're doing it, and essentially then as you change it, you can adapt the information sheet. So there's a good information trail. And this is really the core of why we cannot eliminate the risk of coronavirus. Okay, we can mitigate the risks to ourselves and our patients. So the questions to ask, and the questions that would be asked if it was ever challenged, is: was it reasonably practical to have done more? Do we have an individual approach to patients and staff? And essentially, have we written down what we've done and why we've done it? And if you tick those 3 components, then you are giving excellent evidence of treating this seriously and having a written record to that effect. And again, this is the sort of documentation that the CQC will be looking at. So at a very simplistic level, it is useful to simulate in your own mind the different people in the clinic environment. So you do this for your practice, your surgery, your work, whether you are the primary clinician, so that's easier for you to think about, but also think about it for your first patient, your second patient, other staff members. And then essentially it ends up with a slightly complicated diagram that if you are the primary clinician here, you might have cycled to work, you may be have family at home, you may be shielding, your family may be going to school and contact. So there are lots of different issues just before you even leave the front door. Your patient will want to know whether you're going to give it to them, and you'll want to know whether you're going to get it from that patient. The patient also wants to know who else is in the practice at the same time. Have they been screened? Your staff member, whether it's your nurse in the surgery or your receptionist, will also want to know, and they also have the home situation. So this can look overwhelmingly complicated to start with, but if you just think about it from each individual angle, then it will help, I believe, you to kind of think through the protocols, troubleshoot what will happen if you go, oh, actually, I am a vulnerable patient, or I have been shielding now, but my dental pain is so bad, I have to come out of that. And these things to think through so that when you are faced with them for the first time, they are not completely perplexing. So important that we screen our patients and we also screen our staff. Now, I said before that the prevalence level of coronavirus is thought to be quite low, between 1 in 500 and 1 in 1,000, but essentially we're still looking for that asymptomatic but infectious group. It's allergy season, less so with kind of influenza and things, but again, differentiating between whether you've got a stuffy nose because you're pollen allergic or whether it's because of other symptoms. So again, just having a checklist that is hopefully going to try and screen out the serious infectious causes from the allergenic runny nose causes. And this is, I think, adapted from the Australian guidelines. But again, it's something to be aware of when interpreting your screening. And this is from the Zoe platform done at King's College, where they looked at screening tests and also physical tests of patients, and essentially worked out what were the big differentiators for coronavirus. And interestingly, the strongest one, both in the UK and the States, was the loss of smell. Anorexia, or sort of feeling fatigued, loss of appetite, fever, persistent cough, they score differently. So these are the sorts of things that you can put into your screening questionnaire. This is the one that I happen to use. Different, again, there's not one size fits all. Have a way that you want to do it. You might want to automate this. There are electronic web-based systems that will do this, incorporated into your patient management systems. Personally, I think after patients have been away from the practice for a while, it's good to get to someone physically, to talk to them on the phone, get that interpersonal re-engagement going, ask them some simple questions, screen them with a temperature check when they arrive, write this all down, put it into the patient record. Again, it's an audit trail that you've done it to the best of your ability. We could talk a bit about structuring the diary and social distancing in the practice, and when are you going to do your aerosol generated procedures during your diary? Can you swap the rooms round? I haven't got time to go through all of these things, but I'm happy to pick things up in the questions. So I'm gonna just, shall I pause now and see if there are any particular questions on that point?
Sure, Jonathan. There is one question from Shub. Is there any antibody test with high reliability that you can recommend?
So there are lots of antibody tests. They have different amounts of blood that they're used. There are the finger prick ones. There are ones that are more like a formal blood test. The ones in the hospital that have got the greatest reliability are the tests by Abbott and the tests by Roche. So those two seem to be performing the best at the moment. And those are the ones I would recommend.
Sure. I mean, just to follow up with that, even if you develop antibody, is there any scientific evidence how long it'll protect us from?
Okay, so there's no direct scientific evidence about how protective your antibody level is. They have taken antibodies from patients who have had the virus and given them to other patients with the virus, and they've done better. So there is some immunological effect, as you would expect your immune system to do, but we still don't absolutely know that if you light up positive on the antibody test, that you won't get it again. In what sort of time period? Does it prevent you getting it? Does it reduce the severity of the illness? Certainly, if I became antibody positive, I wouldn't be discarding my other infection control systems or my PPE. So
Sure.
it's not 100% reliable until we know more data.
Sure. Just a couple more questions, John. This is from Jimmy Macadesi. Hi, Jimmy. Hi, John. What is your
Hi, Jimmy.
what's your view on den screen?
Den screen. You have to, Jimmy, you'll have to inform me what den screen is. Perhaps I can come back to that at the end. I'm guessing that's an automated platform for screening dental patients. I think any screening tool, as long as it asks the differentiating questions, it is as robust as it can be. Nothing is going to be perfect. In the hospitals, interesting, if you go and have a hip replacement or a routine operation, you are being tested beforehand and you are being told to isolate for 14 days. So that's fine if you're having a major operation. Patients are not going to subscribe to that if they are just coming in for a routine dental appointment.
Okay. So, John, there are a few more questions. We'll pick up those questions as we go along.
Sure. Okay.
Thank you. Thank you.
So now I'm going to talk a little bit more about PPE. So we'll talk about what it is. And I've done this in a kind of frequently asked question module, because this is the kind of feedback I have when I go around and do fit testing and mask advice and infection control things in local practices and with colleagues. So we'll kind of run through this list of simple things, and then obviously we can follow it up with question and answers at the end. So this is PPE. This is a suit, and there is a tent. This is on the 12th floor of the Royal Free Hospital, and this is where you go if you have Ebola. So depending on the infectivity of the and the mode of transport of the contagion depends on what level of PPE you are required to have. Now, happily, you don't need to wear this for coronavirus, but in the height of the pandemic, when we were performing tracheostomies on patients, this is what I would be wearing, which actually looks a bit scary, but it's not that dissimilar to a kind of extended normal dental PPE. We're just wearing a fluid-resistant surgical gown. We were double gloving, a visor, mask, normal eyewear, so magnification for me, a headlight, because we were doing this outside of the operating theatre, and the only other thing was a form of neck protection, which was improvised from the gown pack. Now, I'm not suggesting that this is what you need for your protection, but you will need to essentially determine what is effective protection and what's comfortable to wear and mold the two together. Because tip from the top, my own personal experience, if you're very uncomfortable in your PPE, you cannot function very well. You won't work well, you'll be stressed and anxious. If your mask is knocking your optics out and you can't see properly, it's a recipe for disaster. So get comfortable in good quality functioning PPE. So PPE comes in all shapes and sizes. This is a photograph from the Sunday Times taken at our sister hospital, and here you can see the nurse is incredibly well protected. She's got a paper suit on, she's got a FFP3 mask, gloves, there's visors around. So what could possibly go wrong? Well, interestingly, her dirty hands are right next door to her portal of entry, and she's not got any eye protection on. So you could have all of the best equipment you want, but if you don't use it properly and you're not careful and assiduous about what you do with it, its efficacy is going to be compromised. So these are important considerations. So respiratory protective equipment comes in lots of shapes and sizes. You can have disposable masks, you can have reusable half masks, you can have different kinds of full face masks with different kind of filters on them. And I'm sure you'll be very familiar with these from various catalogs. I'm going to do a very basic canter through the kind of masks that are involved and what and when they might be useful. So, surgical masks. Essentially, this protects what's outside from you. So, in that regard, the setting where you are in prolonged contact with someone less than 2 meters away from you, okay, is something where a surgical mask is going to be recommended. So currently on London Transport, you wear one of these on the bus, on the tube, on the train. Why? It's to stop you sniffing and snorting and coughing and spreading it to other people. In the dental setting, you may wish to use that if you are not going to be able to screen your staff, so your reception, etc., comfortably away from people without either a screen or 2 meters of separation. There are lots of different kinds of masks. I'll talk a little bit about them in detail in a minute. But again, when you're thinking about vulnerable patients, this is going to be increasingly important. If you're going to bring them into the practice, they don't want to have additional risk of catching it from other patients or your staff. Face coverings. So this is from the government website. They come in different kinds of complexity. So again, they are something that you wear in a confined environment where it is essentially trying to trap those big droplets from you spreading that through the respiratory route to other areas, other people, or other surfaces. So they are all trying to reduce contamination. And it is reasonable for patients to wear face coverings in your waiting room should they wish to. They will be the same sort of thing as the surgical masks. Essentially then, when we're thinking about how we are going to use our respiratory protective equipment, we need to think of things from different angles. So what equipment do we need? Is it the right thing for the job? Is it the right quality? Is it the right protection? Is it compatible with what we do? Again, think the comfort aspect of things. How long are you going to be wearing it? What situation are you going to be exposed? So aerosols or not? How will it interfere with just dealing with the patient, communicating with them, communicating with your fellow staff members? We found certainly in the operating theatre, operating with PPE, it's very hard to communicate with people with all of that stuff on, even if you know them reasonably well. So that has an impact. What do you have to do as an individual to make it comfortable? Do you have to make sure that any facial hair is well trimmed? Are you going to wear glasses? Are you going to wear loops? And then essentially, if you're using reusable equipment, you've got to make sure that it's maintained, stored, it's cleaned, and you have a documentation that that process has occurred. So we'll cover this in a bit more detail in a minute. So again, people are probably getting a better handle on when to use protective equipment. So again, this is new from the guidance from a couple of days ago, really builds on what was done before. But essentially, this is the this is the primary care version. And again, it allows, if you look at the list of the detail, it's talking about use of single sessional use. It can talk about reusable PPE when it's designed to be reused, how you might use face masks for patients. Now, in the hospital setting, you'd certainly put a patient on a face mask on a patient who you suspected have coronavirus. And if you are worried about asymptomatic patients, then it's not unreasonable to put face masks on patients, but it's not an absolute requirement. Again, different kind of gowns, whether they can be reused, how are they reused, or washed. Again, it varies from each one, but this is the current guidance that's been very recently updated. And essentially then, if we look at this for the most relevant setting for dentistry, again, from the directive a couple of days ago, really for primary care, we're looking at whether if you're in an aerosol generating environment, you're going to be using an FFP mask, and we'll talk a bit more about that. A surgical face mask is insufficient, or fluid resistant is insufficient. However, if you are within 2 meters of the patient, but you're not generating an aerosol, then this will be sufficient. Again, if you're in reception and you're inside that 2 meter zone, again, you may wish to consider your staff wearing a fluid resistant surgical mask, and you may or may not invite your patients to wear a face mask depending on the practicalities of that. So if you look at this in a simplistic diagrammatic way, essentially, if you are doing let's talk about this in dentistry, so a simple examination where you're not using instrumentation that will generate an aerosol, then a normal fluid resistant surgical mask is sufficient with gloves and an apron, and only really when you're going for the aerosols do you need to upgrade that to your FFP mask, eye protection, a longer fluid resistant gown and gloves. So what helps protect in the mask? So again, surgical masks, there's more to it a little bit than meets the eye. Essentially, they're divided into type 1 and type 2, and they may have an R. R essentially denotes a degree of splash resistance. So surgical masks are tested by you breathing out. They stop what you breathe out going elsewhere. And if they're type 1, their bacterial filtering efficiency is 95%. And if they are type 2, the bacterial filtering efficiency is 98%. There are quality control standards for them. This is the one that it should be written on the box or the packet, and it is worth looking for those. They come, you're familiar with them, typically pleated. They may have ear loops or ties, and they typically have a 3 or 4 layer construction. The 4th layer basically is on the type 2 to provide the splash resistance. And so if you chop them open, that's what you'll find, 4 layers inside. So they are tested in exhalation. The fitting face piece, or filtering face piece, excuse me, respirators are tested in inspiration. So essentially, this is something that will have 2 main components. You will want it to filter what is outside so that it doesn't get inside. And you will want it not to leak around the seal. So the filtration efficiency is determined by the P number. Okay, so whether it's 1, 2, or 3, and essentially P1 is about 80% efficiency, P2 is about 94% efficiency, and P3 is 99% efficiency. And you'll also see that the face leakage figures are slightly higher in an FFP2 mask than they are in an FFP3 mask. So the main differences between these two is the slight change in filtration efficiency and the slight change in facial leakage, which is basically what happens when you breathe out. How much of the air that you breathe out leaks around the seal, and how much actually goes through the mask itself. Because when they're actually making these masks, essentially they've got to work out, you've got to filter what's going in, but you've also got to be able to breathe through it. So when you breathe in, you filter through the mask. When you breathe out, you may filter back through the mask, or you may have an exhalation valve. And essentially, they are made of a number of filter, essentially pieces of paper, some of which hold an electrostatic charge to attract the very, very small particles. They come in different shapes and sizes. So this is a typical duck bill. This is made by Easy Mask. So no valve on this. This is flat folding. And again, it's a relatively adaptable, simple mask that is often widely available if you can get hold of the FFP3 types. The next is a flat folding mask. So they might fold horizontally, such as the one in the picture, or vertically. Again, this has a filter in the front, and again, it adapts around the face, and it has headbands. Okay, these are really important. Okay, this is how you generate the seal onto the face. You cannot generate enough seal with ear loops, and that is an important consideration when looking at whether the mask will be suitably protective for you. This is an anatomical mask, so if you held this in your hand, it would not be flat, colloquially known as the coconut. Again, this has a valve on it for expiration. It has a nose piece and elasticated straps, which are slightly adjustable. So, different shapes and sizes, and I'll explain a little bit more about the sort of the fits of them in a minute. The Americans use a very slightly different classification of systems. So essentially, they have different filters, so 95, 99, and 100. So 95 maps to the FFP2 and 99 to the FFP3. N essentially just means no oil resistance. Remember, the pedigree of these masks is predominantly from the construction industries. So that's a legacy of that. Because they are American and are essentially classified by their version of PHE in the Occupational Safety and Health Organization, strictly speaking, they are not accepted in the UK, but because of the shortage of PPE initially, there has been dispensation that appropriately badged and marked N95 masks are applicable and suitable to replace FFP2. So the N95 and the FFP2 are equivalent as long as they have the appropriate documentation with it. We'll come back to that in just a minute. So half mask respirators, we're going up the scary scale now, but essentially these are reusable. Again, they fit over the nose and the mouth. They form a seal. They need to be fit tested, and they have particle filters on them, which can be quite bulky. And again, they come in different shapes and sizes depending on whether what you need to filter out. So again, we'd be going for the P2 or the P3 filters for these. They come in different shapes and sizes. This is one of my colleagues at work, and she finds this quite difficult because every time she bends down, this rides up. So again, it's making sure that your mask is fit for purpose, knowing what you are going to do with it. A little bit more complicated still. So this now incorporates the whole face. This seals all the way around. Again, you've got particle filters on the outside. You've got an exhalation valve in the middle. This is not powered, so this is not pushing air around it, but you can get air-powered ones in addition to that, with increasing levels of complexity. As I mentioned before, different filters for different jobs, remembering that the pedigree of these is construction. So if you're taking out organic vapors and acid gas, which happily we're not in the dental setting. So again, it's the P2, P3 filters that you'll be looking for. And essentially then the sort of overall algorithm for this is determining which of these we're going to be using. And most of us will end up in the disposable filtering half mask or the reusable half mask. A few of my colleagues I've seen with these, and very, very few with these. But again, it's what suits you best for the task required. So another question I'm asked a lot, how do I know it's not a fake? Well, you have to have a sort of be skeptical and have an index of suspicion. So this is a mask that only has one thing printed on it, KN95. So KN95 is the Southeast Asian equivalent, meant to be, of the N95. So you think, okay, that's a tight fitting face piece, fit tested, filtering out 95% of the particles. But actually, you will see from this also that there's no kite mark on it, there's no CE mark, there's no NIOSH markings, and it's got ear loops. So if your mask has ear loops on it, it will not seal tightly enough on your face, and it will not offer you the protection of FFP2 or FFP3. If they also kind of bejeweled and things like that, that's another indication that they are not for the healthcare setting. So again, very recently, Public Health England categorically stated that KN95 masks are not the same as N95 masks and should not be used in the healthcare setting. They do not give you, they should not be used in a healthcare setting where a level of FFP2 or FFP3 protection is required. Again, some of these things come with quite impressive certification, and you might look at that and think, oh, that looks pretty good. And you might look up International Certification Registrar, and there is a fairly glossy website for that. But again, you need to sort of drill into the detail of it. You know, look at the authorities, look at the spelling of them. Are they marked? Do they mention what the regulations are? And then it's about common sense and intuition. So actually, interestingly, when you look up the WUI Lazy Cow Industry Trade Company, you can't find any existence for it. And sending this to some of my testing colleagues, they are highly skeptical that these masks were kosher. Okay, so now we've got the kit, we know what mask we want, we're happy it's not counterfeit. How do we know that actually fits us? Well, there are some nuances to fitting the masks. The areas that they fail most commonly is either around the nose or around the chin. So people with a strong nose or people with a receding chin often find that they can struggle to get these properly sealing. Again, test them with your eyewear. If you wear glasses, loops, magnification, headlight, put it on, get the mask on, check that you're comfortable, check it can breathe, check that you can move without dislodging it, and get your fit test with that all on. Otherwise, you know, once you've tested the mask, but it fits differently when in the real situation, the fit test is less valid. So fit testing, it's a legal requirement for all of those tight fitting respirators. So now we're talking N95, FFP2, FFP3, and the reusable ones. The mainstay of it is a qualitative test using a bitter tasting substance, Bitrex, which is tasted by 97% of the population. If you can't taste that, you can have the sweet version. And if you can't manage either of those, there is a quantitative test done with a particle counter, which is a little bit more complicated, but essentially derives the same figure of whether that is an adequate seal for you. But most fit testing, and this is what we do when we go around to practices, we use the qualitative Bitrex method. So a bit scary. We get staff to put the mask on, get their glasses on, wear what they would do for normal practice. Then you popped in the hood after we checked that you're sensitive, and then a few simple exercises, takes about 7 minutes, and staff tolerate it extremely well. And if that then suggests that there is a good fit for you, then you will be appropriately certificated, but that certificate is dependent on you and the mask matching together. It is specific to that mask. So always when you're thinking of fit testing your team, make sure as much as you can that you know which face mask that you're going to be using. The other sensible thing to do, if you can, if you have a large enough practice, is actually learn how to do the fit testing from a trainer, because then you can do this in-house. So in the hospital, during the pandemic, we had 2,500 staff fit tested in the qualitative method. And essentially then we were able to look at that data to see who passed and who failed on each kind of mask. So these are some little snapshots of things. And really the take home message from this is that, it's not one size fits all. Many of these masks do only come in one size because, again, they were designed for construction workers. So interestingly, you can see that this is an anatomical mask of the FFP3 type. And essentially, it was a very good fit for men. And it was less good fit, particularly for Asian women. Now, I fully understand as an orthognathic surgeon that not every Asian female face is the same, but interestingly, the narrower the face, the more slight the chin and the deeper the nose. As I mentioned before, those are the pinch points where these masks tend to fail. And if we look at the easy mask, so we met that one earlier, again, interestingly, this fairly large sample size, we were finding slightly lower pass rates in Caucasian men compared to essentially the other subgroups. So again, you may find what you source doesn't fit everybody, but in my experience of testing and training it, you can usually find an acceptable position of the mask for comfort and protection. So there's quite a lot of nuance in how you actually put it on. Once you are fit tested and it's checked, each time you use it, you should just do a quick checklist of what you are going to expect from your mask. So again, checking the facial hair, check that it's in a good state. Is it really the right one? Is it your one if you're using it sessionally? And then put it on your face, make sure it's a comfortable seal, make sure your glasses are not fogging up. It's all really simple stuff, but you have enough to think about when you're working on patients to not be fussing and fiddling about your face mask. There's more names for facial hair than I ever knew before, but essentially you can't have any hair, even stubble, around the rim of the fit test. And if you do, that mask will fail. And essentially, obviously, if you're clean shaven for your test, but you're a bit stubbly when you're working, then you will be falsely reassured. So it's important fit check procedure just before putting it on each time, that you put it on properly and you tick off all of those things to ensure and give you the confidence that your mask is protecting you as much as possible. Right. I'm going to suggest I'll just finish off the last few slides and then we'll do some question and answer. So aerosol management. This is an issue that originally, as I mentioned before, came out about how these droplets and aerosols would be developed within the sort of sneezing, coughing patients, so now passing it in the population. Actually, when we think about things in the dental setting, it's slightly different. Although you should actually say to patients, well, look, if you're going to sneeze, you need to sneeze and not spray it everywhere. Thank you very much. So in the hospital and again in your practice, you're going to be thinking about zoning things. So where are you going to do procedures that may cause an aerosol? Are they going to be in a certain surgery? Are there going to be areas that you'll keep clean? Where are you going to put your PPE on? Where are you going to take it off? So this concept of zoning is important because although the guidelines were written with hospitals in mind and antechambers, actually at a practical level, you will need to work out how you are going to do this. It is very important that when you put the PPE on, you feel protected, but that you don't contaminate yourself when you take it off. Believe you me, if you've had it on for a few hours, you're desperate to get rid of it as soon as possible. But actually, in the way that mountaineers die most frequently on the way down from the mountain, they're just relaxed, they're not concentrating, they're a bit tired. It's the same with contamination from PPE. And our experience in the hospital suggests that actually staff were well protected by the PPE, but it's most likely that was breached when the stuff was taken off. So zoning, buddying up, making sure that you're careful with your disposal protocols. Again, literally draw a floor map of the practice and work out where each of these are going to occur. When we think about aerosols, it's not just about the aerosol itself. There's about lots of steps before and afterwards, and you need to think about this as a whole package of measures. And I'm going to do this in a very, very simple schematic way. So we talked about how infectious is our patient. We've thought about the lead times, the asymptomatic thing. We've screened them beforehand. We've worked out whether they are vulnerable. We've worked out whether our staff are vulnerable. So what is the starting position? What is the background prevalence? How likely is it that there's active coronavirus in the oropharynx sitting right there? Essentially, if we're not coughed over by the patient, then what is potential source of virus comes from the oronasopharyngeal secretions. So there is some evidence that a mouthwash for the patients beforehand can reduce the viral load. It's been mainly shown in bacterial load, but the extrapolation is into viral load. Can you isolate what you're working on from the rest of the patient? Now, for some things you can, and for some things you can't. Clearly, you can't do a hygiene under a rubber dam, but you may be able to do some procedures, and it's important that, again, you think about mitigating the risk. You're going to try and reduce things as much as possible. Again, when you look around the guidelines for aerosols, now there's so many conflicting and changing guidelines, it's difficult to know where to look. It's difficult to understand which ones to follow. Again, you've got to think back to the concept of what is realistically possible. So what have you done to think about which procedures you're going to do? How are you going to do them? Can you adapt them in any way? And that's where the CDO guidelines were coming from. Can you reduce the aerosolization in the standard procedures you're doing? What's possible without compromising patient care? So are you going to make an aerosol? How are you going to make it? And through what duration are you going to make it during your procedure? Again, these are the considerations, and they're really on a procedure by procedure basis. If an aerosol is going to be generated, you want to contain it as close as possible to the source. So I've seen lots of suction devices, some rather Heath Robinson, some with a kind of face mask near the patient. Clearly, the closer that you can get to removing that aerosol at the point of creation, the more effective that strategy will be. However, it is not realistic to think that a face mask, an extraction fan here, is going to cover it all. So sometimes you're going to be falsely reassured because you just can't see these particles. So again, they are part of a strategy. They are not an individual solution. Ventilation, I think, probably has become a fairly hot topic because ventilation and fallow time obviously has a huge implication on the commercial viability of dentistry going forward. Anything that ventilates your room air to outside is going to be favorable. So directly externally vented air conditioning units are fine. Opening the windows after a procedure is also helpful. Air purifiers will suck in air and they will filter it and clean it, whether it's HEPA or UVC or whatever mechanisms they're going to do. But if the aerosol is being generated up here and your purifier is down there, it doesn't take much to work out that actually the amount of relevant air changes that it achieves is potentially going to be less effective. Now, I know many people have bought air purifiers, and there may be a commercial expectation from your patients to say, oh, look at this, Bobby Dazzling machine that will purify the air. But again, you must be careful that you're not over reliant on the fact that, this box in the corner of your room can cycle the air so many times, but the aerosol has been generated up here. Fallow time, again, that's air changes per hour. If you change the whole the air volume, then you drop it down. So by the time you've done it 5 times, you've removed 99%. Essentially, you're looking at the aerosol and how long it takes for that aerosol to settle and how quickly you can achieve that, achieve essentially 5 to 6 air changes. And the whole idea of the 1 hour fallow time comes from this air changes. This is a hugely debated topic, and currently the guidelines have all erred on the side of safety, and that's why this kind of fallow time of an hour is being bandied about. At an individual level, it's going to be very difficult to challenge that. There will probably be more evidence coming in as ventilation sort of experts change their focus from the hospital setting to the kind of primary care, both medical and dental. But at the moment, that is one of the most difficult areas to challenge because of the lack of science around that. And again, having done the fallow time, so now you've got your exhalation droplets, they've all fallen onto the surfaces, they are all potentially contaminated, and they will need appropriate cleaning. And in that regard, that's back to basics. There's nothing specifically needed additionally to the standard cleaning protocols that were used before. Good use of a chlorine-based disinfection solution, and the protocols are all there. But of course, remember who's doing it. Is it your cleaning staff? Are they vulnerable, etc., etc.? There's a little bit of a knock-on effect. So just putting a few things together now as we draw things to a close. Essentially, risk assessment is mandatory. It is about reducing the risk, showing what steps you've done to improve things as much as is reasonably possible. No one can eliminate the risk, and I would also advise you to share that risk with the patient and ensure that they understand that actually by coming out through the front door to your practice, that they are going to share in an element of risk as well, and they will need to balance that risk and benefit for themselves at an individual level. Yes, there's issues around staff training, simulating things. So just have a practice without a patient, just run through, how the diary might work, how each procedure might work, taking your PPE on, off. Again, practice, practice, practice. It will mean that actually when you're doing it, you're far more comfortable with it. Appropriate certification if that is necessary, and what are you going to do if certain situations occur? So what happens if your patient sneezes in the middle of the waiting room? What happens if the patient turns up and tells you that they're vulnerable? What happens if NHS England contacts you through track and trace and says, actually, the patient that you treated yesterday in your practice has now tested positive? What are you going to do in those situations? So that is probably the next line of things to think about. So sort of stitch into the initial operating protocols. And that is quite individual, and it's impossible to give everyone a broad brush, oh, you need to do X, Y, and Z. But there are resources available should you have issues such as this, and I would always invite you to use those. Something that we found very helpful for doing high-risk aerosol generating patients in the pandemic was this local standard of invasive procedures, or a LOCSIP. Essentially, this is a little checklist for each invasive procedure that you do. In this case, it was tracheostomy, but you can do this for whatever your common procedures. And you think, oh, no, I'm not going to do that for everything I do. But actually, you'll find that probably 80% of your workload is covered by 5 basic interventions. So you're not doing this again and again and again, but it's a useful aid memoir at the beginning. It is a good documentation of what you did, and it can go into the patient record, and it is therefore excellent evidence to suggest that you have done the best you can. Now, this is a very complicated one for tracheostomy. Actually, the dental ones will be much simpler. But again, this is the thing that is going to be useful to identify that you've done all reasonable steps to mitigate the risk at an individual patient level. Other documentation, so this is the face. This is what's generated when you've passed your face fitting. This is the sort of thing that you would do if you're using reusable masks. Again, it's just having these templates in your CQC folder so that A, you're keeping a good record of things, and you've got a good documentation trail that that is the case. So I guess lots talked about coronavirus, lots thought about coronavirus. I think this is quite a good ethos for individuals and practice owners. Essentially, do your best. Think about why you're doing your best. Act responsibly and ethically. Try and stay up to date. And if you try your best and you document that, then actually any subsequent challenge to that will be very, very difficult to sustain. So that draws me to the end, almost exactly an hour. Thank you for your attention. Thank you to Sophie, and not only for controlling the children, but also providing a lot of the infection knowledge based to this. And Centaur, I'm very happy we can do some Q&A if this would be a reasonable point. Oh, Centaur?
I muted myself.
There you go.
Yeah, sorry. Do you want to mention about how you can help the dentist in doing some fit services which you do?
Yes, so happily. So, I mean, we have a small group of people who have worn the PPE and have done the sort of infection aspects of things, and we do go around to practices to do fit testing. I mean, we've predominantly done it in the London area. We also do at an advisory session, so that can be done through Zoom. So people who are unsure about the masks that they have or how to wear them, or just need a bit of troubleshooting, we're also happy to do that. And we also offer a wider sort of infection consultancy, so addressing some of the individual issues and problems. If people are stuck at a certain point or need help with troubleshooting any aspect of that, then yes, we would be very happy to advise in that way. And there's a couple of contact emails at the bottom of the slide there that people would be welcome to write down, and we'd be happy to discuss that with them.
Perfect. That's lovely. It was an amazing overview of what's happening around right now. Jonathan, there is quite a lot of questions. Some you may have answered, but I'll run through it briefly. We can catch up on.
Sure.
So there is a question from Jay. Hi, Jay. Can we swap surgeries to do AGP? Seems like what you said that before, there was some doubt about this.
No, I think that if you are looking at doing multiple AGPs, so I mean, always ideally you could put them in before break times, and then you lay the room fallow. Essentially, if you lie the room fallow to do that ventilation, so maximize the ventilation, don't keep going in and out of it. okay, because during that sort of fallow time, you shouldn't be entering the room, particularly without, strictly speaking, without the protective equipment. And yes, you need to be a little bit careful about what materials you and kit you carry over from one room to the next. That's just standard cross-infection. But yes, it is quite possible to do that, and many practices are doing that. So in a practice of 3 surgeries, for example, they may be using 2 and rotating them.
Sure. And what's your view on using reusable gowns when you're doing the AGP procedures? How do they swap it?
Okay, so so reusable gowns are, I mean, they need to be specified as reusable. You can't take a paper gown and wash it. But I've seen reusable gowns that have been advertised, and they say that they can be washed with certain instructions up to 30, 40 times. Again, yes, if you use standard infection control methods, and that you're not therefore going to contaminate from one patient to the next patient, then yes, that's fine.
Sure. Okay. This is a question from Shrikant. I think we briefly touched on the antibody test kit, which are available to buy online. Are they reliable?
Okay, I'm gonna answer that by not answering that, and I'm going to say that the best antibody kits are Roche and Abbott.
Sure.
Okay, I know from anecdotal experience of my colleagues, they've bought the online ones and got a result, and they've done the other ones and got a different result, and nothing's changed between them. Okay. So I don't believe that the online ones have the reliability of the others, and that is why the hospital doesn't use them.
Okay, fine. This is a question from Sudhir. Do we need to have a test the staff before starting practice, including the dentist?
Test in what way?
I think he's asking for a COVID test.
No. So even in the hospital, we are not being there's no mandatory testing. No. Okay. No. In that regard, no. But you need to have, you need to have a thought about what happens if someone phones in the morning and says, I've got a bit of a cough and a temperature and things like that. Before you might go, okay, great that you can come to work. Now you're going, no, thanks very much. Again, issues around if one of your staff members tests positive and they've been at work potentially during that asymptomatic but infectious period, then you are potentially going to be contacted by track and trace, and you'll be told to all isolate. So slightly cynically, this is why we are now wearing face masks in the hospital, because essentially, if they said to one of us, well, your colleague's gone down, all of you need to isolate for 14 days, you'll wipe out entire departments, basically. So again, remember the social distancing, wearing masks in confined spaces, that's an important thing within your practice, because it means that if you do get contact trace, you are in a better position to actually say, well, yes, we've managed the exposure in the following ways.
Sure. Okay. This is a question from David. If we have a designated non-AGP surgery, do we still need to remove all the dental materials from the surgery, as it is the case with the AGP procedures?
So, I mean, if you have a non-AGP surgery and you have screened patients and staff, then, it is sensible to, remove the clutter. But no, I don't believe that it is going to be necessary to do anything particularly different. But, at the end of the day, it's about, you're not going to have an aerosol that you're going to spray onto the things. But the moment that, for example, something might happen in that environment, where it perhaps wasn't planned. So maybe you're doing a procedure and you got a bit stuck and you're going to have to do something different. Are you then going to be running around clearing it all up in order to make sure that it's not potentially exposed? So again, I'm not a pessimist, but you've got to kind of think worst case scenario. How am I going to deal with this if this happens, if this occurs?
Sure. Okay. This is actually a practical question which Kunal is asking. When doing an AGP like root canal, how does one go about taking X-rays? Are you able to leave the room? And how do we process the X-rays? That's quite an interesting question.
Okay, so I mean, again, yes. I mean, these are. I don't have, unfortunately, the chapter and verse answer, and this is where the common sense aspect of things. You are not going to find a rule book of this is, if you're in situation X, Y, Z, then you do this, that, and the other. So I think this would be written into your operating protocols of how you would essentially minimize the risk of doing this. But you can't stop doing periapicals and endodontic procedures just because of the risk of this. But there may be ways that you could potentially take the film in the room by people in PPE or aerosol PPE, and it is then in some way passed to someone outside of the room and brought back electronically. You have to find a practical solution, and one that works for you, and one that is sensible.
Sure. Okay. Fine. This is one question. We don't know the name. What are your thoughts about patients coming into the practice that might have come back from abroad with regards of not self-isolating for 14 days? If the guidance tells us they don't have to isolate when getting off a plane, is it pertinent to advise them to wait for 14 days before coming for the treatment? This is obviously a pandemic, and there seems to be no absolute answer to this. Where do we stand making our own decision on this legally?
Okay, so so there are some legal structures around this because there will be government directives. It is shifting sands because this is going to change over the next few months. But currently, if you arrive in the UK from certain destinations, there is a legal requirement for you to self-isolate, and going to attend dental treatment in a non-emergency setting is not a reason to break that. So when this was all building up, it was like, oh, if you come from China, you can't come in type thing. Again, you've just got to take each situation on its own merits. So again, you can put in your screening questionnaire, have you been advised by the government to self-isolate? And if they say yes, then you politely say, well, come back when you're finished.
So it's all about record keeping and following.
It's about common sense and record keeping. And also not thinking, oh, I've done the screening questionnaire now, I never have to go back to that, because things will change and something will crop up. And it's about being flexible and adaptable to deal with that, ideally yourself. And if you don't know how to deal with it, don't make it up, ask someone else.
Sure. Okay. This is a question from Sudhir. With all those cumbersome PPE, what happens if we have an emergency collapse in the chair?
Okay, so there is fairly clear guidance from the Resus Council that actually CPR on patients is not an aerosol generating procedure. So although there are some updates to the Resuscitation Council guidelines, your protocols for the management of emergency patients should be exactly the same.
Okay, perfect. And what does the single session extender actually means?
Okay, so ideally, in a world where PPE grew on trees, you'd use one disposable set for each patient and chuck it away. Now, in a real world, that's not sensible, practical, economically viable, or anything else. So essentially, let's talk about face masks. Some face masks are designed to be used again and again, the reusable ones. Okay, so they just need to be cleaned and monitored and logged, and then they can be reused. The sessional use of a disposable mask essentially is according to the manufacturer's instructions. Now, the manufacturers will always play it cautious. I've had I've had people said, oh, I've been told I can use this mask for 28 days. You cannot use a disposable mask for 28 days. Yeah. Strictly speaking, you can use it all day, but not on the following day. Okay, and you can take it off during that day and put it, I recommend, in a small Tupperware container or a small sealed sandwich bag or something like that with your name on it. And as long as you're careful putting it on and taking it off, that you don't contaminate yourself with the potentially infected surface, then that is what sessional use is. And most of the staff using these for prolonged periods on ITU and things will say that for 8 to 10 hours, it's fine. After that, it tends to get a bit soggy and it doesn't work so well and you don't want to wear it anymore.
Perfect. Jonathan, there's a lot more questions that I think we are running out of time.
Okay.
What I'll ask them to do, they can email us the questions and we can answer them by email if needed.
Yeah, we can try. Yeah, and I can, for one I can ask Sophie and her colleagues. I mean, I see a few of them. I don't have the answer for everything, but I'm happy to try and give people a steer.
Sure, we'll do that. And are you happy to pass on your details if somebody is interested in your services? Yeah.
Yeah, for sure.
Okay. It is an amazing webinar. Thanks a lot for your help, Jonathan.
Oh, you're very welcome.
Thank you. And I'll pass on to my colleague Kaushik to take it further from here.
Perfect. Thank you very much. And thanks a lot, Jonathan. It's made us feel in such a better space now after the whole lecture, that we should be able to start implementing a lot of things as we go into the next week. Guys, in the meantime, we have another webinar. I know we have filled you up the whole day with these webinars, and the one in the afternoon is on occlusion, which was on the request of all the members at the Dental Roots community. This was up there, but then we got Jonathan because it was so appropriate for all of us to know the actual needs and requirements of the time. So we will see you back at 3 o'clock. Also, I have another exciting thing. This is again because of a lot of people emailing us on what courses we are running. And for me to tell you that the guys have worked hard behind the scene because the discussions we had over the last few webinars was about we doing a lot of need of what does patient need kind of a dentistry to what does patient want kind of a dentistry. And when you're talking about what does patient want, they want straight teeth, they want replacement to their missing teeth, and those kinds of spaces, which a lot of us don't have or haven't developed our skill sets and how to master those skill sets. This is where I thought this graph makes a lot of sense. There's two ways of learning. One is more or less a passive learning, where you do reading, hearing, YouTubes, Google, and get a lot of information, but how much of it is absorbed and how much of it is implementable, as against an active way of learning, where we are participating in discussions like today. We are sort of implementing ourselves into doing dramatic representations, simulating real experiences, and doing actual real things. Taking this sort of an active perspective, Dental Roots have initiated this active learning platform. Here we are passionate about what we do, and all our trainers share insights designed to equip and enable you to develop a strong foundation, very similar to what Jonathan did for you guys today. And what we offer is basically in every program, there is a benefit from hands-on mental-led training, which is very critical from our point of view. And it helps you to make connections, establish ongoing support and advice, and be a part of the educational movement, which is also very important to increase our skill sets, and also get a good experience about the latest technologies that's available, the new techniques that is available, and the tools of the trade for us to keep growing in this direction. So having said that, the first part of a training program, what we launched today, is a certificate in dental implantology for 2021. It is a certification program spread out over 8 months. there are 8 touch days, 2 days in one module, which is a Friday and a Saturday to minimize any disruptions for your day-to-day working. And very importantly, there are 7 practical sessions in these touch days, which involves watching live surgeries and performing implant placements under supervision. So you are handheld at every stage, and whatever your starting point is, because we know we have members from different walks of life with different experiences, we have structured the courses in a way that it is tailored with you in mind. And with this side, I see that there is a pathway to a brighter future as we go forward. I know all of you are going to be asking what is the investment here, and it's a very attractive investment of £4,995 for the whole course, which includes all the things I explained to you before. All you need to do is to go to the website and pay a deposit of £195 to reserve your place there. Once you've reserved your place there, I think you will be absolutely fine to be reserved, because it's a very limited 15 delegates only course that will be happening. Okay, the venue is Smile Suffolk, which is a dental and implant center. You will have details about that in the course as well. What is your return on investment? So you will improve varied skill sets post-COVID. All surgical and implant restorative aspects are going to be taught hands-on. So basically, your surgical aspect and your restorative aspects, because some of you don't want to do surgeries, you just want to be involved in restorative aspects, but it's nice to know that you are aware of what surgical aspects are going to happen for you to be well equipped with your restorative part of things. So everything hands-on could be very, very useful. All the details for this is on the website that is mentioned below up here. And I am very, very sure this is going to take all of us from whatever need dentistry providers we are towards a kind of a one dentistry providers. With this saying, and with this amount of explanation, I'm trying to thank all of the guys who have helped us to perform a wonderful webinar today. I thank immensely from my heart to Jonathan, because he's taken his time out on the weekend when we requested him, because it was so critical for all of us to have a better understanding of what was going on. There were, as he rightly explained, there was so much information everywhere, so many regulations coming in, and he has sort of bared it all, and he's taken away the myths in the process and has given us a very clear guidelines to go forward. Thank you very much for your time, Jonathan.
You're welcome.
For your time, Senthil and Jay, who's been working on the back end trying to make it a success, and Darshan as well. So guys, let you enjoy the weekend. And for people who are interested in occlusion, we'll join you back in the afternoon. We'll end with this nice video, which shows the venue and the way courses are held at Dental Roots. So thank you all for having participated today. Thank you.
Thank you, Jonathan. Thanks a lot.
Pleasure.
So that is how you
need to make it glamorous as well.
There's a gap there. So that gap will be a very good team set up for myself.
you, John.
Hi. Okay.
Take care. Thanks a lot.
Thanks a lot,
You're
John.
welcome. All right.
Thank
All
you.
the best.
Yeah, I'll catch you soon. Catch up.
Okay.
Bye.
Bye then.
Bye.